issues around COPD and asthma. Live from the United Kingdom, I would like to present Dr. Brian Pickering, who is a senior research fellow and cyber psychologist at the University of Southampton. Brian, take it away.
Thank you. So my name is Brian Pickering from the University of Southampton. Don't get put off by the cyber psychology piece, but you'll understand that in a moment. What I'd like to talk about in this presentation is Pilot 4, which is all about COPD, chronic obstructive pulmonary disease. But of course, I'm not alone in this work. The University of Southampton were teamed principally with MyHealth, who developed the app that I will talk about in a moment, and also with AstraZeneca, who provided some support during the initial part of the pilot. I also don't want to focus particularly on the technical implementation of the machine learning part, but rather to take the application and what we have done with it into the broader context of how patients use it. So I'll be talking about MyCOPD, which is an application that I'll describe in a moment. What we've actually done in integrating the machine learning technology, and then focus a bit more on how people make sense of this, both the clinician and also the patient. And so I will focus quite a lot around the area of what the adoption is of the technology, how people react to healthcare apps of this nature, and some of the interesting behavioral details that we've discovered. So MyCOPD is an app that runs on a personal data device. It's been put together by COPD experts. The clinical lead, Professor Wilkinson in MyHealth, is a recognized respiratory expert. The app itself has been approved by the NHS, and it's been rolled out for some time now. So the intention of this pilot was to see if we could help identify exacerbation events. That's the rapid deterioration of the perception of where the disease is, using lots of information like medical information, demographics, etc. And I'll talk a little bit about the environmental piece. The most important thing, though, is to be able to alert the clinical team that somebody is about to have this kind of deterioration. So as I said, the app is NHS approved in the UK. And what we've demonstrated, as I will show you in a moment, is that machine learning in this environment with the fairly simple data streams that you will see really does work. So MyCOPD has various different parts to it. It includes some educational materials around the disease itself to help patients understand what they are up against. It provides specific support for things like using an inhaler, exercise regimes, etc. And perhaps most importantly here, various checklists so that the sufferer can actually identify where they are, what they should be doing to support their own well-being. And in particular, and especially for this presentation and the information that you will see on the booth, we took two major streams of information. Remembering this is a self-reporting app. On the one hand, there were the CAT scores, which is an objective, validated instrument made up of 8 questions. That's a COPD assessment test, and that gives us an overall score of objectively where the patient is, coupled with the symptom scores. So this is a very simple identification of what the patient themselves feel to be their well-being at that particular time. So normally what happens, this is typical of any clinical engagement, the patient will have face-to-face consultations with a specialist. They're not necessarily always particularly effective in that the patient may forget information between visits. They may be unwilling to disturb, in inverted commas, the clinician who is obviously very busy. But a lot of the information is already available through the health records, and the clinicians will also have access to that. But what we've been focusing on, and what we've done specifically, is to interrupt this in the sense that if we accept the patients actually have valuable information, their perceptions of where they are, what they feel like, how they feel from a day-to-day basis is important. So that's reported via MyCOPD. That will be part of the health record. And then the data scientists in the project, so my colleagues in the University of Southampton, will take both sets of information, so the standard health record along with these self-reports, and try to model those to produce predictions, as say, of exacerbation events. Those predictions will go into a decision support mechanism to be able to support the clinician in where they go next. And if I refer back to Pilot 2, Roland was talking about the study that they did to see the effects of AI support with the medic themselves. So this has a lot of potential. We haven't implemented these yet, and I'll explain that in a moment. But for the clinician, they might get an alert, for example, to say you need to do something, you need to encourage the patient to engage with rehabilitation exercises. You may need to contact the patient and actually have a discussion with them. You may need to advise them that they need to go to hospital. On the other hand, and of course, from a regulatory point of view, this is much more difficult and be part of a follow-on project. We can also, based on these predictions, alert the individual patient, so the app user themselves, that there are certain things which they need to do. And of course, a lot of this is very sensitive, and so it's important that we take our time iteratively moving forward to see what the best mechanisms are to exploit this information. Now, of course, a lot of this would not be particularly helpful if we didn't understand the long-term use of the application. So we started off in the early days of the project. Over the first couple of years, we had a lot of data, and we started to look at how persistent and so how regular individual patients would actually report the symptom and CAT scores. So the bottom figure shows a sort of rapid and exponential decline in the use of the app. And at the top, we've converted this into cumulative probability scores. And what that means, at the blue dotted line, after about a month and a half, a month and 3/4, there's a 50-50 chance that the patients are no longer reporting. After about 9 months, then we're about 80% of patients not reporting. And this is something that we need to investigate further. So if we look, for example, and of course we're all aware that 2020 saw one of the most devastating pandemics in recent history. Now, this patient cohort, of course, are particularly vulnerable. They have a range of respiratory issues, and coronavirus, of course, was induced a respiratory response with a lot of hospitalizations early on until we developed the vaccines, etc., etc. So at the date of the first lockdown, marked as the red line here, we see a very significant increase in the number of patients who register to use the app. So this may indicate that the patients are actually concerned about their risk to their health because of the environmental issues. But going back previously, as far as retention is concerned, it's important, or it will be important as we go forward, to look for the external factors which will encourage people to continue use of the application. On the lower figure there, I reported mean symptom scores, and as you can see, to start off with, in 2017, 2018, as we started BigMedilytics, the average scores are fairly erratic, but they do tend to settle down, and then post-lockdown, what we see is a decline in the symptom scores. And what that means is that the patients themselves are reporting that they are less concerned. Now, this too is important. I mean, during the lockdowns themselves, social distancing measures were introduced. We weren't allowed to go out, etc. So that might actually introduce a feeling of safety. But in addition, then we know from the technology literature itself around healthcare that this feeling that the patient can do something and take control, what's called self-efficacy, is really important to them. And so it may be that through the app themselves, we're seeing evidence that they're comfortable, that they can manage their own situation, even in this unprecedented environment. Taking this further, and I'm sorry, this is a bit of a busy slide, we did an independent survey. It was independent in as much as we didn't go directly to users of the MyCOPD app. There is a very important ethical reason for that, in that if we actually focused on the people who already use the app, then of course, there is benefit to them, and they'd want to say that the app was fantastic and they really like it, etc., etc. So we went to the general public in the UK. Again, this was during the pandemic. We asked people who use apps and people who don't use apps to give us their opinions about various issues that we know from the literature are important. The items highlighted are where there was disagreement between the people who don't use apps and the people who use apps. The most important thing here, so things like using an app takes too much time, or I don't know how to use apps. The non-app users are saying, no, we don't agree with this. We're perfectly comfortable. So there must be another benefit that they need to get. Using a healthcare app on its own might mean that I'm being fobbed off by the health service. We know there are constraints, etc. But again, they disagreed. So we interpret this as an indication that app take-up is actually quite important, and they're prepared to accept it. And the last bit, which I've highlighted here, I'd feel isolated if I developed a serious condition. Now, apart from the MyCOPD, which is of course very important, the World Health Organization identified it as the third biggest killer in 2019. What people are actually telling us is that the app is not necessarily the mechanism to attach to other people, to contact other people, but rather it becomes integrated into how they take care of themselves. We also looked at the individual, as I said, we focused on CAT score, so that's the objective measure, and the symptom score, which is the subjective measure. And if we plot the two over a period of time, then we would expect that low symptom scores, if they reflect the same as what's reported in the CAT scores, to be correlated. So therefore, low symptom scores will go with low CAT scores, high symptom scores would go with high CAT scores. Otherwise, if there are high symptom scores but low CAT scores, then we need to investigate. And similarly, if there are high symptom scores but low CAT scores, we'd have to investigate. And so, as I said before, the blue boxes really represent the expected behaviours. The yellow box at the bottom right-hand side, where the symptom scores are exaggerated by comparison to the symptom scores are reduced by comparison to the CAT scores. We believe this represents a hesitancy on the part of the patient to potentially over-report. Conversely, with high symptom scores but low CAT scores, that they are oversensitive. Now, we actually looked over different seasons, and we saw this sort of convection type movement. So people would move from the different categories over time, which seemed very odd, because why would all of a sudden the symptom scores reduce during the winter unless people were inside more and they felt safer? But we started to investigate some of the behavioural issues around this. For example, that if people are close to an exacerbation, so high symptom score, high CAT score, once that period passes, then they remain hypervigilant for a while before they settle into a routine. Now, all of this behavioural information and the adoption of technology are important correlates for moving the technology forward and understanding how we can get the best benefit to the patients. So what I've been talking about here is not necessarily about the quality of the data, and of course we had issues of missing data, outliers, etc., just like all of the other pilots, but to try and understand, assuming we have quality data, how we get the self-reporting app accepted in the longer term. So we know on the right-hand side that patient reports, both the subjective and objective reports, will lead on the right-hand side, to provide predictors of when exacerbation events are likely to occur, which can be useful for the clinician as well as for the patient themselves. We started to look at environmental factors, which was an original objective anyway. There are lots of publicly available data sources about the weather, about pollution, etc. But just on a sort of data science level, there is a problem with synchronization. When does the reading from the weather, for example, relate to specific patients in a given area? And one of the issues, of course, is then identifying which patient, are they outside, are they inside, are they subject to other factors as well? So we work closely with toxicology colleagues to understand what the issues were, and at the moment there are too many technical issues for us to integrate that. And finally here, the risk of re-identification, of course, increases, because if you're localizing information, then you may actually identify an individual patient. So summarizing, self-reporting acts do provide an important source of information. Even during the challenging times we've been through for these respiratory patients, we saw an increased take-up. Self-efficacy, so their feeling that they are in control, may be an important factor which we will take forward. So as we move forward, we've secured funding to take all of this and identify these issues and explore these issues in the UK to extend the application further. And taking machine learning forward was the basis to get this. So we're quite excited about moving forward. So thank you for that. And if there are any questions, otherwise please visit the booth. My colleagues from MyM Health and also my data scientist colleagues from Southampton are there as well. Thank you.